2019, nCoV, COVID-19, a threat to mankind and role of pulmonologist. Dr. Jalal Mohsin Uddin, MBBS, DTCD, FCPS, Pulmonology. Assistant Professor. NIDCH. Coronavirus Disease 2019, COVID-19, also known as 2019 nCoV acute respiratory disease. Introduction. The 2019 nCoV infection caused clusters of severe respiratory illness similar to severe acute respiratory syndrome and was associated with ICU admission and high mortality. Although most human coronavirus infections are mild, the epidemics of the two beta coronaviruses, severe acute respiratory syndrome coronavirus, SARS-CoV, and Middle East respiratory syndrome coronavirus, MERS-CoV, have caused more than 10,000 cumulative cases in the past 2 decades, with mortality rates of 10% for SARS-CoV and 37% for MERS-CoV. The coronavirus is already identified might only be the tip of the iceberg, with potentially more novel and severe zoonotic events to be revealed. Q.1. What is the novel coronavirus? Coronaviruses are a common cause of colds and other upper respiratory infections. These viruses are found in different species of animals and in some cases can evolve to infect and spread among humans. Q.2. How it spread. In December 2019, health officials in China reported an outbreak of respiratory illness in Wuhan. Initially, many of the people affected had a link to an animal market, suggesting that the disease spread from animal to human. It was later found that numerous patients confirmed to have the disease had not been exposed to animal markets, suggesting that the disease can also be transmitted between people. Coronavirus incubation period, 2 to 14 days. A key factor that influences transmission is whether the virus can spread in the absence of symptoms, either during the incubation period or in people who never get sick. Chinese officials says that transmission could occur during the incubation period also. Q.2. What are the symptoms? Generally, the virus is characterized by mild to severe respiratory illness with symptoms of fever, cough, and shortness of breath. There have also been reports of non-respiratory symptoms including diarrhea and vomiting. Symptoms can surface in as few as 2 days or as many as 2 weeks after exposure. The Lancet. Volume 395, Issue 10223. P 497 506, February 15, 2020. Clinical features of patients infected with 2019 novel coronavirus in Wuhan, China. Professor Caroline Huang, MD, Yeming Wang, MD, Professor Xingwen Li, MD, Professor Lilai Ren, PhD, Professor Jianping Zhao, MD, Yi Hu, MD et al. Published January 24, 2020. The study revealed common symptoms at onset of illness were fever in 98% cases, cough in 76% cases, and myalgia or fatigue in 44% cases. Less common symptoms were sputum production 28% cases, headache in 8% cases, hemoptysis in 5% cases and diarrhea 3%. Dyspnea developed in 55% cases of 40 patients, median time from illness onset to dyspnea 8.0 days. Complications and other findings. 63% patients had lymphopenia. All 41 patients had pneumonia with abnormal findings on chest CT. Complications included acute respiratory distress syndrome in 29% cases, rheumia in 15% cases, acute cardiac injury in 12% cases and secondary infection in 10% cases. ICU, non-ICU patient. 32% patients were admitted to ICU and among them 15% died. Compared with non-ICU patients, ICU patients had higher plasma levels of IL-2, IL-7, IL-10, GSCF, IP-10, MCP-1, MIP-1A, and TNF-alpha. Q.4. Who are at risk? The probability of infection for those traveling, resident in areas where ongoing sustained community transmission is considered moderate to high. Many patients recover from 2019 nCoV in as little as a few days, while others, such as the younger, elderly, and those with a weakened immune system, are more prone to serious infection. Those who have died from the illness tended to have underlying health conditions such as hypertension, cardiovascular disease, diabetes, chronic lung disease, cancer, heart failure, cerebrovascular disease, renal disease, liver disease, diabetes and pregnancy. Comparison with other viruses. For comparison, the case fatality rate with seasonal flu in the United States is less than 0.1%, 1 death per every 1,000 cases. Mortality rate for SARS was 10%, and for MERS 34%. In dengue fever mortality rate is less than 1%. Laboratory test. The WHO has published several testing protocols for the disease. Testing uses real-time reverse transcription polymerase chain reaction, RRT, PCR. The test can be done on respiratory or blood samples. Results are generally available within a few hours to days. Chinese scientists were able to isolate a strain of the coronavirus and publish the genetic sequence so that laboratories across the world could independently develop PCR tests to detect infection by the virus. Diagnosis. Diagnostic guidelines released by Zhongnan Hospital of Wuhan University suggested methods for detecting infections based upon clinical features and epidemiological risk. These involved identifying patients who had at least two of the following symptoms in addition to a history of travel to Wuhan or contact with other infected patients. Fever. Imaging features of pneumonia. Normal or reduced white blood cell count, or reduced lymphocyte count. Computed tomography, CT, findings have been characterized for patients infected with the 2019 novel coronavirus, 2019 nCoV. According to research published online February 4 in Radiology. Michael Chung, MD, and his colleagues reviewed a case series of chest CT scans from 21 symptomatic patients from China infected with 2019 nCoV to identify and characterize the most common findings. The researchers found that bilateral pulmonary parenchymal ground glass and consolidative pulmonary opacities were typical CT findings. Sometimes with a rounded morphology and a peripheral lung distribution. Follow-up imaging demonstrated mild or moderate disease progression as manifested by increasing extent and density of lung opacities. 3 of the patients had normal chest CT examinations at presentation. Management. While there are no specific antivirals against this disease, the resulting clinical manifestations and complications are managed with supportive therapy. The WHO has published detailed treatment recommendations for hospitalized patients with severe acute respiratory infection, SARI, when nCoV infection is suspected. Research into potential treatments for the disease were initiated in January 2020, and new therapies may take until 2021 to develop. In late January 2020, Chinese medical researchers expressed an intent to start clinical testing on remdesivir, chloroquine, and lopinavir, ritonavir. as they have effects against other coronaviruses and modes of action that suggest they may be effective. The Beijing branch of China's National Health Commission stated that there is currently no effective antiviral medication available. It suggested the use of lopinavir, ritonavir as part of treatment plans. However, WHO has provided a management plan for adult and pediatric patients with severe acute respiratory infection, SARI. When 2019 nCoV infection is suspected, following measures can be taken. 1. Recognize and sort patients with SARI. 2. Immediate implementation of appropriate infection prevention and control, IPC, measures. 3. Early supportive therapy and monitoring. 4. Collection of specimens for laboratory diagnosis. 5. Management of hypoxemic respiratory failure and acute respiratory distress syndrome, ARDS. 6. Management of septic shock. 7. Prevention of complications. 8. Specific anti-nCoV treatments. 9. Special considerations for pregnant patients. When persons are infected 2019 nCoV, they may suffer from mild to severe pneumonia, acute respiratory distress syndrome, sepsis, even septic shock. In these conditions, following measures are advocated. Highlighted and relevant supportive therapy and monitoring will be discussed briefly. 1. Supplemental oxygen therapy immediately to patients with SARI and respiratory distress, hypoxemia, or shock. Initiation of oxygen therapy at 5 liters per minute and titrate flow rates to reach target SpO2 greater than or equal to 90% in non-pregnant adults and SpO2 greater than or equal to 90–95% in pregnant patients. 2. Use of conservative fluid management in patients with SARI when there is no evidence of shock. Patients with SARI should be treated cautiously with intravenous fluids, because aggressive fluid resuscitation may worsen oxygenation. 3. Initiation of empiric antimicrobials to treat all likely pathogens contributing to SARI. Antimicrobials should be given within 1 hour of initial patient assessment for patients with sepsis. Although the patient may be suspected to have nCoV, administer appropriate empiric antimicrobials within 1 hour of identification of sepsis. Empiric therapy can include a neuraminidase inhibitor for treatment of influenza when there is risk factors. 4. Closely monitor patients with SARI for signs of clinical deterioration, such as rapidly progressive respiratory failure and sepsis, and apply supportive care interventions immediately. Application of timely, effective, and safe supportive therapies, invasive and non-invasive, is the cornerstone of therapy for patients that develop severe manifestations of 2019 nCoV. 5. Collections of specimens from both the upper respiratory tract, URT, nasopharyngeal and opharyngeal, and lower respiratory tract, LRT, expectorated sputum, endotracheal aspirate, or bronchoalveolar lavage, for 2019 nCoV testing by RT-PCR. Serology for diagnostic purposes is recommended only when RT-PCR is not available. 6. The decision to monitor a patient in the inpatient or outpatient setting should be made on a case-by-case basis. This decision will depend not only on the clinical presentation, but also on their patient's ability to engage in monitoring, home isolation, and the risk of transmission in the patient's home environment. 7. Corticosteroids should be avoided unless indicated for other reasons, for example, chronic obstructive pulmonary disease exacerbation or septic shock, because of the potential for prolonging viral replication as observed in MERS-CoV patients. Specialized respirators are key to stopping spread of coronavirus to medical staff. As of February 14, About 1,716 medical workers in China have contracted COVID-19, and 6 of these workers have died. The high rate of infection may be blamed, in part, on inadequate hand disinfection and sparse use of N95 respirators, which are designed to filter out virus particles. The N95 designation means that the respirators block out at least 95% of tiny particles that come into contact with them, on the scale of 0.0001 inches, 0.3 microns, in diameter, according to the U.S. Food and Drug Administration. Q.5. How can the disease be prevented? In the absence of a vaccine, it is the best way to prevent infection and spread of respiratory viruses is to avoid exposure to the virus and take precautionary actions. 1. Thoroughly wash your hands with soap and water. 2. Avoid touching your eyes, nose, and mouth with unwashed hands. 3. Keep a distance from people who are sick. 4. Stay home if you're sick. 5. Cover your cough or sneeze with a tissue, then dispose of the tissue in the trash. 6. Clean and disinfect surface. Q.6. How concerned should you be? Some experts contend that the novel coronavirus is not something you should worry about on a personal level. Unless you've been in close contact with someone who has the coronavirus, which right now, typically means a traveler from Wuhan, China who actually has the virus, you're likely to be safe. Thanks to all. It is better to stay safe than to have an accident.